Whereas those who have idiopathic buccal overgrowth who are elderly people, clindamycin and metronidazole is the treatment of choice. And in the children who have younger than 1 year, gentamicin is considered to be the treatment of choice is what need to be remembered. So finally, the answer becomes the doxycycline by all this logic. Let's go to the next question. CVA is commonly because of the emboli, all of you know very well. Patient has got a chronic diarrhea, another challenging question. Who has got a normal Deek xylose and a normal Schilling test, then what is the possible diagnosis? I'll take a couple of minutes on this question because you need to know basically what do you mean by Deek xylose test fundamentally. Very simple. There's a small funda in this. Remember doctor, if a 72-hour fecal fat collection has demonstrated that there is a steatorrhea and malabsorption and you want to know what is the cause for that malabsorption, you'll be doing the Deek xylose test. Tell me doctor, 3 important reasons why the malabsorption can occur. It can be because of the pancreatitis, because of which pancreas is not able to deliver the enzymes required for the breakdown and the absorption of the substances. It can be any problem within the mucosa of the gastrointestinal tract, malabsorption can occur. So what is the cause for this malabsorption you need to evaluate, then you will be doing this very important test called Deek xylose test. Now what is this test basically? Facilitated diffusion in the proximal intestine will be absorbing the Deek xylose, and about half of this absorbed Deek xylose will be excreted in the urine in an unmetabolized manner. Suppose if the absorption of the Deek xylose is impaired, then you need to suspect probably there is a luminal factor like the bacterial overgrowth syndrome, or probably there is a mucosal disease like surgical resection of the celiac disease of the small intestine. Either of them will make the Deek xylose absorption to become impaired, and even the urinary levels of the Deek xylose after you have orally given it become diminished. Whereas in the case of the pancreatitis, Deek xylose test will not be abnormal. The people with malabsorption because of the pancreatitis typically will be having Deek xylose unaffected, and they produce the same amount of the urinary levels of the Deek xylose as a normal individual is what need to be remembered. So quickly summarizing doctor, what you need to remember is you can have a pancreatic insufficiency, or you can have a mucosal disease, or you can have a bacterial overgrowth. Any of these things can be responsible for the development of the malabsorption. Deek xylose will be normal only in pancreatic insufficiency but not in the other 2 entities. That is the reason the answer becomes the chronic pancreatitis is what need to be fundamentally remembered. Let's go to the next question quickly. Kusumal sign typically is seen in which condition? Another favorite question of the examiner. So remember, there is a small twitch here. It does not mean cardiac tamponade will not have the Kusumal at all, but if you consider all the 4 will show Kusumal sign positivity. But in the case of the cardiac tamponade, it is little rarer, is what need to be basically remembered. So what is Kusumal? Before we say goodbye to this, JVP normally falls with the inspiration, because heart become filled and JVP will fall. But anything that is impairing the filling of the right ventricle will prevent the filling of the JVP into the heart, and the JVP remains raised even at the time of inspiration, which is called as the Kusumal sign. So constrictive pericarditis, restrictive cardiomyopathy, right ventricular infarction, all the conditions where the right ventricle cannot be filled will make inspiratory phase also the JVP remain elevated instead of falling down, is called the Kusumal, is what need to be remembered. Let's go to the next question. Advanced bone age typically is seen in which is the important condition. So please, I'll take 1-2 more minutes of time on this question, doctor. Basically, what do you mean by bone age, doctor? Epiphysis at a particular age is expected to mature. So based on the epiphysis, you will expect that he is having this much of age. But if chronological age is taken, suppose if the chronological age is lesser, but his bone epiphyseal maturation is like a very elderly individual, you call it as an advanced bone age. Suppose if his age is very elderly person but epiphyses have not yet matured, then it is called retarded bone age. Now what causes advanced bone age? Precocious puberty, congenital adrenal hyperplasia that lead to a prolonged elevation of the sex steroid levels that will mature their epiphysis and that will make their bone age to become advanced is what need to be basically remembered. Similarly, Beckwith-Wiedemann syndrome, Marshall-Smith syndrome, premature adrenarche, in all these situations the bone age become advanced. There are certain situations like the growth hormone deficiency, hypothyroidism, constitutional growth delay, in all these situations bone age become delayed is what need to be basically remembered. So finally, what is your answer, doctor? Congenital adrenal hyperplasia, precocious puberty, obesity, in all the situations there is a high exposure to the steroids. As a reason the epiphyseal maturation become much more advanced is what need to be basically remembered. Let's go to the next question. In the bronchiectasis, what is the congenital pulmonary anomaly which is commonly associated? I can't forget the first and of course the last patient of Kunir-Moon syndrome, which is called congenital tracheobronchomegaly. Their trachea, options are different, there are some other options given. But is this congenital tracheobronchomegaly is there in the options? It's not there? Okay, majority I am hearing there. So, okay, if it is not there, no problem. You can just mention it. But anyway, let us talk about tracheobronchomegaly, one of the very interesting situation. Trachea is so big in these patients with the tracheobronchomegaly, you have never intubated also. If you push the intubation tube, it won't go into esophagus, it will go into trachea. I still remember that patient, about 6 times we intubated. Every time intubated, once more his oxygen levels come back and it is taken off. His daughters, everybody will come. Thank you, doctor, wonderful performance. And then coffee is drunk. By night, suddenly hypoxemia develops, patient arrest, and you have to run and then do the intubation. So, tracheobronchomegaly, otherwise called the Kunir-Moon syndrome, should not be forgotten. There is a marked dilatation of the trachea and the main bronchi. Bronchiectasis will be developing in them, and recurrent lower respiratory tract infection. This combination is called tracheobronchomegaly. This is a typical radiograph of this patient, doctor. You can see this is the trachea. Don't you think this tracheal shadow is very much wide? Definitely. In fact, the normal coronal diameter will be less than 26 millimeters in men and 23 millimeters in the case of the women. But in this given individual, it will be so big that almost it will be equal to the width of the thoracic vertebra is the tracheomegaly of the tracheobronchomegaly patients. If you take the HRCT, the marked dilatation of the tracheobronchial tree is clearly evident in them. They will also have bronchiectasis. So congenital cause for the development of the bronchiectasis, congenital tracheobronchomegaly should not be basically forgotten. Let's go to the next question. Congenital diaphragmatic hernia. Is it more on the left side, doctor? Definitely. There are 3 congenital diaphragmatic hernias. So you can see heart is onto the left, no? So here also you are seeing herniation. So it is the left sided is more common. Diaphragmatic hernia is what need to be remembered. So you have a posterolateral Bogdalek hernia, and you have an anterior Morgangis hernia and the hiatus hernia, 3 common types. Out of this, the left-sided Bogdalek hernia is nearly common in 90% of cases, and in them, the small and the large bowel will be typically herniating is what need to be remembered. Now, if it herniates, what happens to the left-sided lung, doctor? It becomes hypoplastic. If it becomes hypoplastic, it can't expand well. If it can't expand, pulmonary alveolar hypoxia will be there. That will lead to pulmonary vasoconstriction, which will predispose to pulmonary hypertension. So there's a reason, doctor, one of the practices to manage this pulmonary alveolar hypoxia and pulmonary hypertension in the congenital diaphragmatic hernia is to give the pulmonary vasodilators. Can you tell me one drug which can be used for that purpose as a pulmonary vasodilator, which is also used for managing impotence? Sildenafil can be wonderfully used in primary pulmonary hypertension, and also those who have congenital diaphragmatic hernia is what need to be basically remembered. That's the reason, doctor, mortality is because of this pulmonary hyperplasia. Giving the pulmonary dilators improves the survival, and it's more common in the left side is what has to be fundamentally remembered. Let's go to the next question. In a patient who has got galactosemia, who is on the galactose-free diet, can still produce the galactose because of which enzyme which transforms glucose to galactose, doctor? It is the UDP hexose-4 epimerase is what need to be remembered. So please remember, doctor, galactose becomes galactose 1-phosphate by the galactokinase action, and the galactose 1-phosphate becomes glucose 1-phosphate by the action of the galactose 1-phosphate uridyl transferase. You have an epimerase which is existent, which can interchange between these two, is what need to be basically remembered. Finally, phosphoglucomutase will convert glucose 1-phosphate to glucose 6-phosphate, and that will enter into the process of glucose, and glycolysis is what need to remember. That's how galactose is used for the glycolysis.